Usually when we talk about treating a trauma wound, like in the emergency department, there's this baseline expectation of straightforward plumbing, I guess.
Right, exactly, like structural plumbing.
Yeah, you get a laceration, you clean out the macroscopic debris, you approximate the edges, suture the gap so it stops leaking, and then you essentially point to it and say, there you go, good as new.
It's a very mechanical mindset. You close the physical gap, you restore the epidermal barrier. And, there is a clinical comfort in that.
Definitely.
We inherently like things to be visible, physically categorized, and structurally fixed.
But then you step into the clinical management of animal and human bites,
Yeah.
and suddenly that straightforward plumbing job is a massive, potentially fatal trap.
Oh, absolutely.
Because we aren't just looking at structural damage. We are looking at a microscopic landscape that is, quite honestly, a ticking time bomb. What looks like a tiny, perfectly benign puncture is, well, it's something entirely different when you understand the vector mechanics.
It is the absolute definition of a deceptive injury. What looks like a minor break in the skin, just a superficial break in the stratum corneum, is very often a deep, targeted injection site.
Yeah.
It's delivering some of the most specialized, aggressively pathogenic organisms known to medicine directly past our primary immune defenses.
Wow. So welcome back to another deep dive. Today we are acting as your ultimate clinical study partners. Our mission is to help you completely master a highly comprehensive, incredibly crucial clinical slide deck, simply titled BITES.
Right, and that's by Dr. Megbelaine Fadikimi, dated November 17th, 2025.
Exactly. Whether you are prepping for a high-stakes clinical rotation, studying for your medical boards, or you just want to know the exact, unassailable protocol for the next time an animal bite presents in your triage bay, this is exactly where you need to be.
And we are going to be incredibly rigorous today. The material in this presentation represents the razor-thin margin between a routine, manageable ER visit and a truly catastrophic, rapidly fatal outcome.
We're unpacking the exact clinical pathways for dog bites, cat bites, human clenched fist injuries, and this is the big one, the absolutely terrifying, flawless virology of rabies.
It really is flawless.
To make sure you retain every single high-yield exam point and clinical pearl from this deck, we're going to rely on a dynamic, read-and-explain clinical approach.
I love this method.
Me too. I'm going to pull the raw clinical facts, the data points, and the epidemiological stats directly from the presentation. And as soon as we establish that baseline, we're going to unpack them together.
Right. We'll break down the underlying pathophysiology, the nuanced clinical reasoning, and provide the diagnostic frameworks you need to lock this into your clinical memory.
Because I think that's the only way to tackle material this dense. We can't just memorize algorithmic flowcharts. We have to understand the underlying molecular and mechanical why.
Exactly. Because when you truly understand the pathophysiology of an organism or the physics of an injury, the treatment protocols don't just become rules. They become logical, unavoidable conclusions.
Perfectly said. Okay, let's unpack this. The presentation opens by establishing the baseline definition of a bite as the use of teeth to cut into or through something. Now, bites account for a massive volume of ER visits.
Massive.
But the source material gives us a fascinating, almost counterintuitive clinical paradox right up front. The data clearly states that most fatalities are due to dog bites. However, the vast majority of infected bite wounds actually come from human and cat bites.
That is a critical distinction, and it really dictates your entire initial triage mindset.
How so?
Well, when we look at dog bites causing immediate fatalities, we are almost exclusively talking about acute, massive physical trauma. Dogs, particularly larger breeds, have tremendous jaw musculature.
Right, they can generate an immense amount of kinetic energy.
Exactly, often exceeding 300 to 400 pounds per square inch of crush force. So they cause exsanguination, severe tissue avulsion, blunt force trauma to underlying organs, just massive structural damage.
But when we transition to cats and humans,
the teeth are operating differently. They aren't primarily blunt force weapons. They are acting as highly efficient biological vectors for infection.
So if the initial physical trauma doesn't kill the patient, the secondary infectious cascade is where we lose the battle.
Precisely.
That moves us logically into the first step of clinical management, identifying the high-risk wounds. We have patients sitting in front of us. What are the immediate red flags?
Right, let's look at the criteria.
Okay, I'm reading from the slide on the clinical landscape of bites and wound risks. It states, infection is the commonest complication. And then it defines high-risk bites as including hand, foot, or genital wounds, penetration of bone or tendons, human or cat bites, a delay in presentation greater than 24 hours, the presence of foreign material, immunosuppression, specifically noting asplenia, and crush or deep puncture wounds.
Let's dissect that anatomic risk profile first, because it perfectly illustrates the intersection of anatomy and immunology.
Hands and feet, right?
Yeah, the deck explicitly flags the extremities. Why are these so much more dangerous than a laceration on the thigh or the torso? It comes down to distal vascularity and tissue architecture.
Meaning blood flow.
Exactly. The hands and feet are terminal capillary beds. They naturally have a less robust arterial supply compared to central structures. So when virulent bacteria are introduced into an area with marginal perfusion, the host immune system severely struggles.
It just can't get the troops there fast enough.
Right. It can't mobilize macrophages, neutrophils, and systemic antibodies to the site in sufficient numbers.
But wait, I'd imagine a bite to the face,
Mm.
which is highly vascular, bleeds a lot more. Yet, from an infectious disease standpoint, the face actually has a better prognosis than a bite on the knuckle.
That's exactly right. The intense vascularity of the face that causes such dramatic bleeding is exactly what protects it.
Oh, because the white blood cells can get there immediately.
Yes, the immune system can swarm a facial wound with white blood cells within minutes. The hands and feet lack that immediate, robust supply.
That makes sense.
Furthermore, your hands are tightly packed with tendons, synovial sheaths, bones, and joint capsules, all crammed together with very little protective adipose tissue or muscle bulk to absorb an injury.
So bacteria get in there.
Once bacteria breach a synovial tendon sheath in the finger, that sheath acts like a biological superhighway. The infection can travel rapidly along the length of the flexor tendon, completely unimpeded by normal tissue boundaries.
Yikes.
It leads to catastrophic conditions like purulent flexor tenosynovitis.
And regarding the genitalia, which this slide also flags, that tissue is highly vascular but uniquely structured, right?
Yeah.
It's incredibly distensible and porous.
Yes, which makes it highly susceptible to rapid edema and severe, spreading necrotizing soft tissue infections. The loose areolar tissue planes allow an infection to spread unimpeded. Fournier's gangrene is a classic terrifying example of that.
Let's shift to the type of wound. The presentation specifically singles out crush or deep puncture wounds. You mentioned earlier that a bite can act as an injection site. That perfectly aligns with the danger of a puncture wound over a wide laceration.
It does, and the biomechanics of a cat bite illustrate this flawlessly. Cat teeth are long, slender, and incredibly sharp.
Like little needles.
Literally. When a feline bites, it rarely tears or avulses the flesh. It punctures it. It acts exactly like a biological hypodermic needle, driving the oral flora from the cat's mouth deep into the subcutaneous tissue and often straight into the periosteum, or a joint space.
And because it's a puncture, the elasticity of the skin just seals that microscopic entry wound right back over, right?
Yes, the tissue recoil is immediate. You are left with a tiny dot of dried blood on the surface, while underneath you have just deposited a concentrated inoculum of bacteria into a warm, moist, perfectly sealed environment.
So you've completely cut off the oxygen supply.
Exactly. That is the ultimate breeding ground for facultative and strict anaerobic bacteria. This is why a puncture wound is universally considered an astronomically higher risk than a wide, gaping laceration that bleeds freely and remains open to ambient oxygen.
That makes profound clinical sense. The very act of the skin sealing itself is what creates the lethal anaerobic chamber.
It's a perfect trap.
Now, let's look at systemic risk factors. The slide highlights immunosuppression, but it specifically singles out asplenia, the absence of a functioning spleen. If I'm an ER resident and a patient with a dog bite mentions they had a splenectomy 5 years ago following a car accident, why should alarm bells immediately start ringing?
Because the spleen is the unsung hero of the reticuloendothelial system. It is a massive blood filter and the primary staging ground for clearing bloodborne pathogens.
The specifically encapsulated bacteria.
Right, exactly. Encapsulated bacteria have an outer polysaccharide layer that makes it incredibly difficult for normal neutrophils to recognize and phagocytize them. The macrophages in the splenic tissue are uniquely specialized to capture and destroy these encapsulated organisms once they are tagged by antibodies.
So without a spleen, that filter's just gone.
Gone. If a patient is a splenic, whether from surgical removal or functional asplenia like we see in sickle cell disease, they lack this crucial filtration mechanism. They are at a severe, life-threatening risk for overwhelming post-splenectomy infection, or OPSI, from the bacteria introduced by the bite.
You must treat an spawning patient with absolute maximum clinical aggression.
Without a doubt.
So we've defined the highest risk anatomy and the highest risk systemic profiles. Let's look at the actual epidemiological data of who is walking through the door. I'm going to pull the specific demographics for dog bites from the deck.
Go for it.
The data states occur most often in children between the ages of 6 to 11 years. Boys are attacked more often than girls at a 1.5 to 1 ratio. Approximately two-thirds of the attacks occur around the home. 75% of the biting animals are known by the child.
That's a huge stat.
Yeah, and it continues. Almost 50% of the attacks are said to be unprovoked. Younger children have a higher incidence of head and neck wounds. School-aged children are bitten most often on the upper extremities.
What's incredibly telling here is how clearly the epidemiological data paints a picture of human behavior intersecting with physical anatomy.
Let's look at the age stratification and the location of the wounds.
Right. The data shows younger children, toddlers, and infants are overwhelmingly presenting with head and neck wounds. Why? It's pure physics and spatial orientation.
A toddler stands about 2 to 3 feet tall.
Exactly. Their cranium and face are perfectly aligned with the eye level of a medium to large standing dog. When a dog snaps, the closest, most immediate target in its strike zone is the child's face or neck.
It's a grim visualization, but the mechanics make perfect sense. It's not that the dog is selectively aiming for the head. The head is simply the only thing in the operational radius.
Exactly, and this introduces a massive, non-negotiable trauma concept for anyone managing these cases.
Yeah.
Because a toddler's skull is still relatively thin, and depending on their exact age, their fontanelles and cranial sutures might not be fully fused. A dog bite to the head is never just a soft tissue laceration. You have to treat the animal's jaws like a high-velocity, penetrating weapon.
Dr. Fedekemi's presentation stresses that you must have a high index of suspicion for a depressed skull fracture or an occult penetrating brain injury in infants with cranial dog bites.
You must image them. A CT scan is often mandatory. Do not just irrigate the superficial laceration, throw in some sutures, and discharge them.
Right, because if a tooth penetrated the calvarium, you are looking at a direct inoculation of oral flora into the meninges.
Which is a nightmare.
And then the data shifts as the child grows. It notes that school-age children, the 6 to 11 demographic, are bitten most often on the upper extremities.
Right, because an older child has both the height advantage and the developed motor reflexes to throw their arms up in a defensive posture when an animal lunges.
So the dog's trajectory meets the forearm or the hand instead of the face.
Yes. The clinical pattern shifts from potential neurosurgical trauma to defensive extremity wounds, which brings us right back to the danger of hand and tendon infections we just discussed.
Now, there is a statistical reality in this slide that I think challenges our conventional assumptions. It says 75% of the biting animals are known to the child, and two-thirds of attacks happen in or around the home.
It's a sobering statistic.
It really is. When we think of dangerous dog bites, the cinematic image is the rabid, foaming stray dog in a dark alleyway.
Yeah.
But the data unequivocally states it's usually the golden retriever next door or the family's own pet.
Yeah.
So if 3/4 of these dogs are known to the victim, how does that alter our initial risk stratification, specifically regarding rabies?
It drastically alters your immediate clinical pathway, assuming you're practicing in a region with robust veterinary infrastructure. If the animal is known, belongs to a neighbor, and the owner can produce a verifiable, up-to-date rabies vaccination record, the immediate existential threat of rabies is effectively neutralized.
So the clinical concern shifts entirely to bacterial prophylaxis and structural repair.
Exactly. In fact, standard public health protocols often state that if the dog is known and healthy, you don't immediately initiate the agonizing post-exposure rabies prophylaxis on the patient. Instead, you quarantine and observe the dog for 10 days.
Okay, wait, let me challenge that for a second. Why exactly 10 days? If the incubation period of rabies can be months, why does a 10-day observation period of the dog prove the patient is safe?
That is a brilliant question, and it touches on the precise virology of shedding. An animal only sheds the rabies virus in its saliva after the virus has reached its brain and begun replicating in the salivary glands.
Okay.
Once the virus has permeated the central nervous system to that degree, the animal will inevitably display severe, fatal neurological symptoms within just a few days.
I see.
Therefore, if the dog bites someone, and 10 days later the dog is still walking around acting normal, it is biologically impossible for the dog to have had rabies in its saliva at the moment of the bite. The virus wasn't in the salivary glands yet.
Wow, that is an incredibly elegant clinical safeguard. However, that entire protocol relies on knowing the dog, and living in an area where observation is possible.
Right.
But the reality is vastly different depending on the global region. Let's pivot from the domestic pet to the global reservoir of what is definitively the deadliest zoonotic virus on the planet. Let's dive deep into the epidemiology of the rabies threat.
Let's do it.
I'm looking at the data on the global burden. It states, dogs are the reservoir of rabies infection, especially in most developing countries. Stray dogs account for 99% of cases of rabies transmission worldwide. Rabies is more prevalent in developing countries than in industrialized countries.
The numbers are staggering.
The WHO reports 35,000 to 40,000 deaths in Africa, Asia, and Latin America, with more than 95% of human deaths occurring in Asia and Africa.
We really need to pause and contextualize the sheer magnitude of those statistics. We are talking about roughly 40,000 human beings dying every single year from a disease that has a 100% effective preventative vaccine.
And 99% of the time, the victor is a stray, unvaccinated dog.
Yes. The slide uses the term zoonotic. A zoonotic disease is any infectious agent that naturally transmits from vertebrate animals to humans. Rabies isn't just a zoonotic disease, it is the absolute apex predator of zoonotic diseases.
And the geographic disparity is staggering. Over 95% of the mortality is concentrated in Asia and Africa. It perfectly highlights that rabies is no longer a question of medical mystery. It is entirely a question of public health infrastructure.
Exactly. If a region lacks aggressive stray dog population control and mandatory subsidized vaccination programs, the virus simply continues its unbroken chain of transmission through the mammalian reservoir.
Speaking of that reservoir, let's look at exactly who is susceptible. The deck lists the vectors explicitly. It says any mammal can get rabies. Raccoons, skunks, foxes, and bats. Dogs, cats, cattle, and ferrets. Humans, too. Mammals are warm-blooded animals that have hair and mammary glands to produce milk. Animals like frogs, birds, and snakes do not get rabies.
This creates an ironclad triage rule for the emergency room. If a panicked patient runs in because they were bitten by a feral iguana, or aggressively pecked by a wild parrot, or snapped at by a turtle, you can instantly, definitively cross rabies off your differential diagnosis.
The rule is absolute.
Yeah.
Only mammals, birds, reptiles, and amphibians are universally immune to the rabies virus.
They're completely immune.
But biologically, why is that barrier so absolute? I mean, a virus is just a package of genetic code looking for a host.
Yeah.
Why does it care if the host has feathers or fur? Why specifically the mammalian lineage?
It comes down to millions of years of highly targeted evolutionary specialization. The rabies virus doesn't just bump into cells and absorb into them. It requires highly specific protein receptors on the surface of the host's nerve cells to gain entry.
Receptors like what?
Specifically nicotinic acetylcholine receptors and neural cell adhesion molecules, or NCMs. The molecular structure of these specific receptors is highly conserved across all mammals, from a bat to a human to a cow.
Oh, I see.
But the orthologs, the equivalent receptors in birds and reptiles, have vastly different structural folding and amino acid sequences. The virus's attachment proteins literally do not fit the locks on a bird's nervous system.
That is fascinating.
Add to that the differences in core body temperatures and cellular replication machinery, and the virus simply cannot function outside the mammalian physiological environment.
It's a biological lock and key system, and the virus only carries the master key for one specific branch of the evolutionary tree.
Perfectly said.
Now, looking at the historical context provided in the slides, it notes that the etymology of the word rabies comes from the Latin rabas, which translates to frenzy or uncontrolled wild behavior.
Which is an incredibly accurate description of the clinical outcome.
Yeah, the deck is chillingly brief about that. It states, once symptoms of the disease develop, rabies is fatal.
It is the absolute terrifying fatalism of the disease. There are virtually no other infectious pathogens in the modern medical canon where we have to tell a patient with 99.9% certainty that once the clinical symptoms begin, mortality is guaranteed.
Right? I mean, we can manage aggressive HIV. We have curative therapies for hepatitis C. We can put advanced leukemias into remission.
But once the rabies virus successfully breaches the central nervous system and triggers that Latin rabas, that neurological frenzy modern medicine is effectively powerless.
To understand why it's so lethal and why our sophisticated, highly evolved immune system is so utterly blind to it until it's far too late, we need to completely shift our perspective. We need to zoom into the microscopic level and look at the physical, molecular architecture of the virus itself.
Let's do it.
The presentation breaks down the virology of the Lysovirus genus. It reads, Rhabdovirus family, genus Lysovirus. Lyssa means rage. Enveloped, bullet-shaped virions. Size is 180 by 75 nanometers. Contains unsegmented, linear, negative sense, single-stranded RNA.
Let's dissect the architecture of this microscopic assassin because every detail dictates its lethality. First, the morphology. It is uniquely shaped like a bullet.
A literal bullet.
Yeah, when viewed under an electron microscope, it has one distinct flattened end and a rounded conical apex. It is a highly organized, tightly packed physical structure, 180 nanometers long and 75 nanometers wide.
But the truly critical detail in that slide is the genetic payload. It specifies negative sense single-stranded RNA. For the clinicians who haven't reviewed their advanced virology recently, what are the mechanical implications of a virus carrying negative sense RNA?
This is the crux of its replication strategy. In typical human cellular biology, when your DNA wants to manufacture a protein, it transcribes a piece of messenger RNA, mRNA.
Right.
That mRNA is positive sense, meaning it is essentially written in the correct language. The cell's ribosomes can read it directly and instantly start assembling proteins.
Okay, so what about viruses?
If a virus carries positive sense RNA, like the poliovirus or SARS-CoV-2, it just dumps its genome into the cell. The host ribosomes read it immediately, and viral replication begins instantly.
But rabies carries negative sense RNA.
Yes, it is the exact mirror image, the reverse complement of the code. If a host ribosome tries to read it, it is biochemical gibberish. It makes absolutely no sense to the cellular machinery.
Wait, so if the host cell can't read it, how does the virus ever replicate?
It has to carry its own translator. Because the host cell lacks the ability to transcribe negative RNA into positive mRNA, the rabies virion physically packs its own specialized enzyme, an RNA-dependent RNA polymerase, inside the bullet casing.
Oh.
When the virus enters the cell, it first uses its own polymerase to transcribe its negative sense genome into positive sense mRNA. Only then can it hijack the host's ribosomes. It essentially smuggles its own darkroom equipment into the cell to develop its genetic negative before it can take over the host factory.
It's remarkably self-sufficient. But how does this microscopic bullet actually breach the host cell to set up this darkroom?
Let's look at the surface.
The deck details its antigenic properties next. It states, surface spikes composed of glycoprotein G produces pathogenicity by binding to acetylcholine receptors in the neural tissue.
Stop right there. If you only commit one molecular fact to memory from this entire deep dive, it must be this. This is the ultimate high-yield virology pearl.
Glycoprotein G.
Glycoprotein G is the skeleton key. The outer lipid envelope of the bullet is studded with these trimeric spikes made of glycoprotein G. And these spikes do not just randomly adhere to any epithelial cell or muscle fiber they bump into. They are precision engineered to bind specifically and with incredibly high affinity to acetylcholine receptors.
Here's where it gets really interesting. It specifically targets acetylcholine receptors. And where do we find a massive concentration of those receptors? Right at the neuromuscular junction.
Exactly. Acetylcholine is the primary neurotransmitter that your motor neurons use to tell your skeletal muscles to contract. The neuromuscular junction, the exact microscopic synapse where the terminal end of a peripheral nerve meets a muscle fiber, is densely packed with nicotinic acetylcholine receptors.
So picture the sequence. A rabid animal bites your calf muscle. The virus is deposited into the muscle tissue.
And then it uses its glycoprotein G spikes to flawlessly mimic your own endogenous neurotransmitters. It approaches the neuromuscular junction, inserts its glycoprotein G key into the acetylcholine receptor lock, and the nerve cell is tricked into actively endocytosing or swallowing the virus.
It believes it is receiving a normal chemical signal.
Yes. It doesn't use brute force to break the cell wall down. It uses a forged biochemical ID badge to trick the nervous system into eagerly opening the front door. It selectively chooses the body's communication highway as its entry point.
That is just brilliant in a terrifying way. Now let's examine the variations of this virus and, critically, its chemical weaknesses. The presentation differentiates the strains and lists their environmental sensitivities. It defines a fixed virus as one whose virulence and incubation period have been stabilized by serial passage and remain fixed during further transmission. Rabies virus that has undergone serial passage through rabbits called fixed virus.
Right.
It defines a street virus as virus from a naturally infected animal as opposed to a laboratory-adapted strain.
Okay, so street is the wild type.
Exactly. And then it details the vulnerabilities. Rabies viruses are sensitive to common chemicals. Destroyed at 50 degrees Celsius in 1 hour, at 60 degrees Celsius in 5 minutes, sensitive to ethanol, iodine, soap detergents, ether, chloroform, acetone.
The differentiation between the fixed and street strains is a phenomenal piece of medical history that informs our modern vaccines.
Tell me about it.
When Louis Pasteur was conducting his pioneering work on rabies in the 1880s, he isolated the wild, highly unpredictable street virus from the medulla of a rabid dog. He took that virulent strain and repeatedly injected it into the brains of live rabbits. He would let the virus replicate, harvest the rabbit's spinal cord, extract the virus, and inject it into the next rabbit.
That's his serial passage.
Exactly. Over dozens of passages, evolutionary pressure forced the virus to adapt perfectly to the neural environment of the rabbit. Its incubation time became rigidly predictable. It became fixed.
But in doing so, it lost its edge.
Yes, in gaining absolute efficiency in rabbits, it lost its pathogenic ability to reliably cause fatal disease when introduced peripherally into humans or dogs. This weakened, attenuated, fixed virus became the exact biological foundation for the very first post-exposure rabies vaccines.
So Pasteur essentially forced the virus to hyperspecialize in a foreign host until it forgot how to efficiently murder a human.
That's a great way to put it.
But what immediately catches my clinical eye is the list of its chemical sensitivities. For a virus that is historically known as an unstoppable 100% fatal juggernaut, it seems shockingly fragile the moment it is outside the human body.
It is remarkably fragile, and I want you to lock in a simple mnemonic for its vulnerabilities. The rabies virus is instantly destroyed by the EISA protocol. EISA, ethanol, iodine, soap, and acetone.
EISA, E-I-S-A. But why? Why does something as mundane as hand soap destroy an apex virological predator?
It all comes back to the structural slide we reviewed earlier. The slide noted the virus is enveloped. That means the viral bullet, along with all its deadly genetic cargo and glycoprotein G spikes, is encased in a delicate lipoprotein bilayer, essentially a microscopic bubble of fat.
Ah, and we know exactly what soap does to lipids.
Exactly. Soap is a surfactant. It contains amphipathic molecules that have a hydrophilic head and a hydrophobic tail. When you introduce soap to the virus, the hydrophobic tails wedge themselves right into the lipid envelope of the virus.
Like chemical shrapnel.
It literally rips the viral membrane apart. The envelope dissolves, the glycoprotein G spikes fall away, and the internal RNA is exposed and immediately neutralized.
Wow.
This is the exact pharmacological reason why the absolute first, non-negotiable medical intervention for any mammalian bite wound is copious, high-pressure irrigation with soap and water. You aren't just washing away dirt. You are engaging in targeted chemical warfare against the structural integrity of the viral envelope.
So if we fail at that first step, if the wound isn't aggressively irrigated, and that bullet-shaped virus successfully uses its glycoprotein G to pick the lock at the neuromuscular junction, what happens next?
Then the journey begins.
Right. How does a virus deposited in a calf muscle physically navigate to the brain? Let's trace this journey by diving into pathogenesis and the retrograde hijack.
Let's pull up the pathogenesis slide.
Dr. Fidegami's presentation outlines the initial invasion phase. Transmitted via abrasions, mucous membrane exposed to saliva, or most frequently via deep penetrating bite wounds. Other routes include inhalation in bat-infected caves, ingestion of dead infected animal meat, or corneal transplantation. Virus multiplies in the muscle, connective tissue, and nerves after 48 to 72 hours before penetrating nerve endings.
We have to focus relentlessly on that final sentence. The virus remains localized, multiplying in the skeletal muscle and connective tissue for 48 to 72 hours. This localized amplification phase is the most critical concept in rabies post-exposure management.
Because that's our therapeutic window.
Precisely. While the virus is in the muscle, it is exposed to the extracellular environment. It hasn't fully sequestered itself inside the nervous system yet. If we intervene aggressively during this amplification phase with passive antibodies and active vaccines, which we'll detail in the PEP protocol, we win.
The virus is tagged and destroyed before it can board the train to the brain.
Exactly.
And regarding the timeline, the incubation slide notes it's typically 1 to 3 months, but the absolute range can be anywhere from 7 days to upwards of 3 years.
That massive variance in incubation time is governed entirely by two factors: the sheer viral load inoculated during the bite and the anatomic distance from the bite site to the central nervous system. But regardless of whether the mathematical incubation is projected to be 2 weeks or 2 years, the initial 48 to 72-hour pause in the peripheral muscle tissue is the golden hour of rabies management.
But if we miss that window, the commute to the central nervous system officially begins. The slide details the transport mechanism meticulously. It says, virus travels through axoplasm toward the spinal cord at the rate of 3 millimeters per hour, or 12 to 24 millimeters per day. Moves by retrograde transport. Rabies is a highly neutrophilic virus that evades immune surveillance via sequestration in the CNS.
Let's break down the cellular logistics of this transit. The axoplasm is the specialized cytoplasm flowing inside the axon, the incredibly long, cable-like projection of a nerve cell that transmits electrical impulses.
Okay.
Now, motor nerves are designed to send signals anterograde down the axon, away from the spinal cord, out to the muscle.
Right, normal traffic flow.
But the rabies virus has evolved to hijack the internal transport machinery of the nerve cell. It binds to a specific motor protein called dynin. Dynin naturally moves cargo retrograde backwards up the axon toward the cell body. The virus literally latches onto this molecular motor and is dragged backwards against the normal flow of electrical traffic, creeping slowly up the peripheral nerve, heading straight for the dorsal root ganglion and the spinal cord.
It's essentially jumping onto a unidirectional subway track and forcing the train car to go in reverse.
That's a perfect analogy.
And the data specifies it moves at a rate of 12 to 24 millimeters per day. Let's think about the practical clinical implications of that speed. If a patient sustains a severe bite on their ankle, and the virus is restricted to moving roughly half an inch to an inch a day, it has to physically travel up the entire length of the sciatic nerve, up the spinal cord, to reach the brainstem.
That is a massive anatomical distance.
Which explains why a bite on the foot can have an incubation period of 6 months to a year.
Precisely. But if we look back at the demographics where a toddler is bitten on the cheek or the neck,
then the math becomes terrifying.
Exactly. If the inoculation occurs in the facial muscles, the virus enters the cranial nerves, often the facial nerve or trigeminal nerve. The anatomical distance to the brainstem is now measured in mere inches, not feet.
The incubation period collapses from months to a matter of days.
Yes. That is why any bite to the head, neck, or highly innervated areas like the hands is considered an absolute screaming medical emergency demanding immediate immunoglobulin infiltration.
And the slide explicitly notes that it evades immune surveillance via sequestration.
This is the biological horror of the pathogenesis. Because the virus is physically encapsulated inside the axoplasm of the nerve fiber, it is functionally invisible to the host's cellular and humoral immunity.
Because the immune system is in the blood.
Right. Macrophages, cytotoxic T cells, circulating antibodies, they all travel via the vascular and lymphatic systems. They patrol the bloodstream and the extracellular matrix. They cannot penetrate the myelin sheath and peer inside the axon of a living nerve.
So the virus is moving through a secure, private, biologically privileged tunnel, completely shielded from immune detection.
Completely. By the time the virus reaches the central nervous system and triggers a systemic immune response, it is already safely behind the blood-brain barrier, replicating uncontrollably in the neurons.
And once it hits the central nervous system, the slow, methodical retrograde crawl turns into a devastating high-speed explosion.
It really does.
The next phase of pathogenesis reads, towards the brain and spread quickly at rate of 200 to 400 millimeters per day into the brain. Rapidly progressive encephalopathy. Spread from brain centrifugally to various parts of the body. Multiplies in the salivary glands and shed in the saliva. Also spreads to cornea, facial tissues, skin, conjunctival cells released into tears, kidney, and lactating glands milk.
Notice the sudden, massive acceleration in velocity. It jumps from 12 to 24 millimeters a day in the peripheral nerves to 200 to 400 millimeters a day once it accesses the spinal cord and brain.
That's exponential.
It rapidly permeates the entire cortical and subcortical architecture, causing massive cellular dysfunction without necessarily destroying the neurons immediately, which leads to the progressive encephalopathy.
And then the slide describes a centrifugal spread.
Centrifugally means moving outward from a central point. The virus has successfully conquered the brain. Now it reverses direction again. It uses anterograde transport down the cranial nerves to push outward to the peripheral organs.
And look at its primary evolutionary target, the salivary glands.
Yes. The virus actively replicates in the acinar cells of the salivary glands, heavily concentrating massive viral titers into the host's saliva. It is quite literally weaponizing the host's mouth, perfectly preparing the host to become the next aggressive vector to bite and propagate the cycle.
It is incredibly insidious. It infiltrates the tears, the kidneys, the skin, even breast milk. It completely permeates the host from the inside out, using the brain as the central command hub.
It's a complete systemic takeover.
And as the virus wreaks havoc on the central nervous system, the clinical symptoms begin to manifest in the patient in a terrifying, highly predictable sequence. Let's move into the clinical phases, tracing the decline from the initial prodrome to the final hydrophobia.
Let's go through the stages.
The presentation lists the symptoms of phase 1, the warning signs. Stages of the disease: prodrome. Symptoms include headache, fever, sore throat, nervousness, confusion, and pain or tingling at the site of the bite. Hallucinations.
I want to isolate one highly specific pathognomonic symptom from that list: pain or tingling at the site of the bite.
Why is that so specific?
Well, if an unvaccinated patient presents to the ER with a generalized fever, headache, and a sore throat, the differential diagnosis is incredibly broad. It could be influenza, it could be bacterial meningitis, it could be severe malaria, depending on the endemic region.
Sure.
But if you take a thorough history and the patient mentions that a completely healed dog bite wound on their calf from 2 months ago has suddenly started burning, intensely itching, or shooting neuropathic pain, that is a massive, highly specific red flag.
Why does a completely healed scar suddenly start burning months later?
Remember the pathogenesis. The virus has been slowly traveling up the sensory and motor nerves. As it reaches the dorsal root ganglion and begins to aggressively multiply, it causes intense localized inflammation and dysfunction, a severe ganglionitis.
Oh, wow.
The brain interprets that intense nerve inflammation as severe pain, paresthesia, or intense pruritus, mapped exactly to the dermatome of the original entry site. It is the definitive clinical indicator that the virus has finished its peripheral incubation and has breached the central nervous system.
And once that breach occurs, the patient rapidly transitions into phase 2. I'll pull the clinical findings for acute neurologic encephalitis.
Okay.
Lasts 1 to 2 days to less than 1 week. Symptoms include excessive motor activity, excitation, agitation, bizarre aberrations of thought, seizures, muscle spasms, meningismus, opistotonic posturing, mental aberration leading to coma, fever over 40.6 degrees Celsius, dilated irregular pupils, lacrimation, salivation, perspiration, upper motor neuron paralysis.
What you are reading is the complete systemic collapse of the autonomic nervous system.
Yeah.
The patient is exhibiting profound dysautonomia.
Right, all those fluid secretions.
Yes, they are producing massive amounts of tears, which is lacrimation, sweat, or perspiration, and thick, ropey saliva hypersalivation because the parasympathetic and sympathetic brain centers are inflamed and firing chaotically.
And the fever, 40.6 Celsius, is over 105 degrees Fahrenheit. The hypothalamic temperature regulation centers are completely offline.
Absolutely offline.
The side also lists opistotonic posturing. That's an intense piece of clinical terminology.
Well,
What exactly are we observing in the bed when that happens?
episotonos is a severe, rigid, involuntary arching of the spine and neck. It is caused by uncontrollable tetanic spasms of the axial musculature.
Why the arching specifically?
Because the extensor muscles along the posterior spine are vastly stronger than the flexor muscles in the anterior abdomen. When the inflamed brain loses all inhibitory motor control and all muscles fire simultaneously, the stronger back muscles win the tug of war. They pull the spine violently backwards into a terrifying rigid arch. It is a classic grim sign of profound brainstem and extrapyramidal damage.
That sounds absolutely agonizing for the patient. And it leads directly into the most famous and undoubtedly the most cruel hallmark symptom of the disease.
Hydrophobia.
Yeah. The slide on hydrophobia states, hydrophobia or aerophobia in 50 to 70% of cases. Patients have intense thirst, but are afraid of water because spasms of the pharynx produce choking. Even the sight or sound of water disturbs the patient.
This specific symptom represents the dark, evolutionary genius of the rabies virus. We established earlier that the virus's entire reproductive strategy hinges on heavily concentrating itself in the salivary glands.
Right.
To successfully spread to a new host, the virus absolutely requires that infected, highly concentrated saliva to remain in the host's mouth, frothing and ready to be transmitted via an aggressive bite.
So, if the host drinks a glass of water, the infected saliva is washed down the esophagus and into the stomach.
Exactly. And where the highly acidic gastric environment would instantly destroy the delicate lipid envelope of the virus.
Right, reverting back to our isomnemonic, the virus is structurally fragile to acids and detergents.
Exactly. So, to actively prevent the host from diluting and swallowing the viral payload, the virus specifically targets the nucleus ambiguous and other critical brainstem nuclei that control the complex mechanics of swallowing and respiration.
It's actively defending itself.
It is. It induces excruciating, violent, choking spasms in the pharyngeal and laryngeal musculature the exact moment the patient attempts to swallow liquids.
God, that's horrific.
The physical pain is so severe, and the resulting laryngospasm creates such a terrifying sensation of acute suffocation that the patient rapidly develops a profound psychological phobia of water. Eventually, even the mere sight of a glass of water or the sound of water pouring from a faucet is enough to trigger the reflex spasms.
So you have a patient who is actively dying of systemic dehydration, burning up with a 105-degree fever, experiencing intense physiological thirst, but who is violently terrified of a cup of water.
Yes, the virus is flawlessly hijacking the host's neurology to guarantee its own survival and transmission.
And from that agonizing peak, it is a rapid, irreversible decline into phase 3.
The final phase.
The presentation outlines the end. Phase 3, the end. Mental aberration, lucid period leading to coma. Respiratory arrest. Death in 1 to 6 days. Some may survive.
I must address that final note. Some may survive. While there are exceptionally rare, historically documented case studies of individuals surviving rabies after the onset of encephalitis, most notably the Milwaukee Protocol case involving medically induced comas and antivirals, those instances are extreme statistical outliers.
Right.
For the explicit purpose of standard clinical practice, emergency triage, and board examinations, rabies must be considered functionally 100% fatal once neurologic symptoms begin.
What's the ultimate cause of death?
The profound cerebral edema ultimately causes the respiratory centers in the medulla to completely herniate or shut down, and the patient simply stops breathing. This absolute finality cements why aggressive, immediate post-exposure prophylaxis is the single most important intervention.
Which brings us to the most critical phase for the clinician. If a patient presents to triage with an animal exposure, how do we confirm the risk, and what is the exact protocol to save their life? Let's move into diagnostics and the PE protocol.
Let's start with the WHO categories.
Okay, the presentation outlines the WHO categories for patient history and wound assessment. Category 1, touching or feeding suspect animals but skin is intact. Category 2, minor scratches without bleeding from contact or licks on broken skin. Category 3, 1 or more bites, scratches, licks on broken skin, or other contact that breaks the skin, or exposure to bats.
These 3 categories strictly dictate your algorithmic clinical response. Category I requires absolutely no medical intervention. You touched a dog, your epidermal barrier was completely intact, you wash your hands, you go home.
Makes sense.
Category 2 exposures require immediate aggressive wound washing and usually the initiation of the active vaccine series.
And Category 3.
We must laser focus on Category 3. This is the highest risk category requiring the absolute maximum prophylactic protocol. And notice the very last phrase Dr. Fedekemi includes, or exposure to bats.
Yeah, that phrasing is very specific. It doesn't say a confirmed bat bite. It just says exposure to bats.
That is a massive, potentially fatal trap for young clinicians in emergency medicine. A patient walks into the ER and says, "I woke up this morning and there was a bat flying around my bedroom. I opened the window and shoot it out. I checked my arms. I don't see any bite marks on me, but I wanted to be safe."
Now, what do?
You must automatically trigger a full Category 3 response. As we discussed with the puncture mechanics of cats, bat teeth are microscopically thin and incredibly sharp. A bat can land on you in your sleep, bite you, and leave a puncture wound so imperceptibly small that it does not bleed, does not cause pain, and is completely invisible to the naked eye.
Wait, really? The standard of care is that if you are just in the same room as a bat while sleeping, you get the full vaccine protocol.
Yes. The clinical rule is absolute. If you are in a room with a bat and you cannot definitively, continuously prove you were awake and visually aware of the animal the entire time, meaning you were asleep, intoxicated, or it was a young, non-verbal child in the room, you must assume a Category 3 exposure occurred.
Wow.
Do not waste time hunting for a microscopic bite mark. Assume the exposure and treat immediately.
That is an incredible clinical pearl. But what about testing the animal if we have it? Let's look at the actual diagnostic testing, the gold standard.
The Negri bodies.
Yeah, the investigation slide states, wound microscopy culture sensitivity. Negri bodies are a gold standard in diagnosis. These inclusion bodies are 100% diagnostic for rabies infection, but found only in 20% of cases.
Okay, we need to unpack the cellular pathology of Negri bodies. If you euthanize the suspect animal and take a biopsy of its brain tissue, specifically targeting the Purkinje cells of the cerebellum or the pyramidal cells of the hippocampus, and you stain that tissue and view it under a microscope, you might see these distinct dark or eosinophilic clumps floating inside the cytoplasm of the nerve cells.
And those are the Negri bodies.
Yes. Those clumps are Negri bodies. They are not the virus itself. They are essentially massive viral factories, dense aggregations of replicating ribonucleoproteins, and viral assembly materials.
But the clinical utility of this test seems completely paradoxical.
Yeah.
The slide says they are 100% diagnostic, but only found in 20% of cases.
It is the ultimate classic lesson in distinguishing diagnostic specificity from sensitivity. Specificity means if the test is positive, how certain am I that they have the disease?
Okay.
Negri bodies have 100% specificity. If you visualize a Negri body in a neuron, that animal definitively, absolutely had rabies. There is no other pathology in the world that produces them.
But what about sensitivity?
Sensitivity means if the disease is truly present, how often will the test actually catch it? The sensitivity here is abysmal, only roughly 20%. So in 80% of confirmed fatal rabies cases, you will not see Negri bodies under the microscope.
So, practically speaking, if public health tests the dog's brain and says, we didn't see any Negri bodies, you still cannot confidently tell the patient they are safe.
Exactly. A negative Negri body test does absolutely nothing to rule out rabies. Now, in modern forensic pathology, we largely rely on direct fluorescent antibody testing, or RT-PCR, of brain tissue, which is vastly more sensitive. But for board exams and classical pathology, you must understand the limitations of the Negri body.
So, for the patient sitting in front of us right now, we can't rely on a rapid microscope test. We can't rely on their immune system to catch it. We can't wait to see if they develop paresthesia. We need the immediate clinical protocol.
We need to act.
We need to know exactly what to do the second a patient walks through the ER doors with a high-risk bite. Let's break down the strict clinical management and PPP protocol.
Let's start with wound care.
I'm pulling the immediate wound care directives from the deck.
Right.
Wash the wound out with soap and water. Inform the doctor right away. Apply pressure if bite is actively bleeding. Wounds should be sutured only if necessary for cosmetic reasons because wound closure increases the risk of infection.
We immediately deploy our ISA mechanism. Soap physically destroys the delicate lipid envelope of the rhabdovirus. Copious high-pressure irrigation with a soapy solution is the single most critical immediate action.
But the second directive is equally crucial for bacterial management. Sutured only if necessary.
Yes. We touched on this when discussing the anaerobic environment of cat punctures. If a German Shepherd violently tears open a patient's forearm, your surgical instinct is to aggressively debride the edges, align the tissue planes, and place tight, beautiful sutures to close the gap perfectly.
Which is exactly what you would do if they cut their arm on a piece of clean glass.
Right. But a dog's oral cavity is heavily colonized with a massive array of facultative and obligate anaerobes. If you suture that heavily contaminated bite wound tightly closed, you are purposely trapping that bacterial inoculum deep inside the fascial layers, completely sealing it off from ambient oxygen.
Creating a nightmare.
You are essentially guaranteeing the formation of a massive destructive abscess or a spreading necrotizing infection.
So what is the standard practice? You just let it bleed.
You achieve hemostasis with pressure, you irrigate aggressively, and then you typically leave the wound open to heal by secondary intention. This means the wound heals gradually from the base upwards, remaining open to the air, which is highly toxic to anaerobes, and allowing any purulent exudate to continuously drain.
What if it's on the face?
If it is a massive, gaping laceration on the face where cosmetic outcome is a severe priority, you might loosely approximate the epidermal edges with a few strategically placed sutures to guide healing, but you never, ever seal a contaminated bite wound completely tight.
And what exactly are the bacteria we are trying to avoid trapping? The presentation lists the common pathogens.
Fair.
It reads, pathogens that infect dog bites include Pasteurella multicida, Streptococci, Staphylococci, and anaerobes. Infected dog bites can be treated with penicillin for P. multicida, and broad-spectrum coverage can be provided by amoxicillin and clavulanic acid or cephalexin.
Pasteurella multicida is the undisputed star of the show when we talk about domestic pet bites. It is a gram-negative coccobacillus that heavily colonizes the respiratory tracts and oral cavities of both dogs and cats.
What does it do clinically?
Clinically, it is notorious for causing a highly aggressive, rapidly spreading cellulitis, often manifesting with severe erythema, swelling, and intense pain within just 12 to 24 hours of the bite.
Oh, that's fast.
The pharmacological good news is that, unlike many modern superbugs, Pasteurella multicida remains highly susceptible to penicillin-based antibiotics. Amoxicillin clavulanic acid, commonly known by its brand name, Augmentin, is the absolute gold standard first-line prophylactic antibiotic for high-risk dog and cat bites.
And why the combination drug? Why not just plain amoxicillin?
Because while the amoxicillin beautifully targets the Pasteurella, dog bites are polymicrobial. They also contain staph and strep species that often produce beta-lactamase, an enzyme that destroys regular penicillin. The clavulanic acid is a beta-lactamase inhibitor. It acts as a chemical shield, protecting the amoxicillin so it can do its job against the broader spectrum of bacteria.
Okay, so we've vigorously washed the wound to destroy the viral envelopes, we've left the wound open to drain to prevent anaerobic abscesses, and we've prescribed amoxicillin clavulanic acid to systematically eliminate the Pasteurella.
Step 1 complete.
Now we must address the ultimate threat. We must intercept the surviving rabies virus before it escapes the peripheral muscle tissue and boards the dyning train up the axon. I'm looking at the post-exposure prophylaxis, the PEP protocol. This is an incredibly precise dual shield approach.
Yes, passive and active.
First, the slide details passive immunization. Human rabies immunoglobulin, HRIG. High risk bitten on face and neck. Given a dose of 20 IU can aid wait for as long as 7 days. Half at the site of bite and rest IM route. Active immunization should be initiated with passive immunization.
This is your immediate Vanguard defense shield number 1. Because the incubation period can potentially be as short as a few days for a facial bite, we simply do not have the luxury of waiting 2 weeks for the patient's own immune system to manufacture antibodies.
So we provide immediate borrowed immunity.
Exactly. HRIG, human rabies immunoglobulin, is a highly concentrated serum of preformed neutralizing rabies antibodies collected from heavily vaccinated human donors.
The dosage parameters are incredibly strict, exactly 20 international units per kilogram of patient body weight. And the physical delivery method is fascinating. The DEC mandates half at the site of the bite and the rest intramuscularly.
This is a highly specific, critically important physical maneuver in the ER. You literally take the syringe filled with the calculated dose of HRIG and you meticulously inject it directly into the subcutaneous tissue and muscle in and immediately surrounding the physical bite wound.
Right into the wound itself.
You are purposefully flooding the exact tissue space where the virus is currently undergoing its 48 to 72-hour amplification phase. You want those neutralizing antibodies to physically intercept and bind to the virus before it can even approach the acetylcholine receptors at the neuromuscular junction.
And the rest goes IM.
Whatever volume of the dose is left over after thoroughly infiltrating the wound margins is injected intramuscularly at a distant site to provide systemic circulation.
So the HRIG provides the immediate, localized, mercenary defense, but it doesn't last forever. Now we need the long-term adaptive defense.
The vaccine.
The presentation details active immunization, post-exposure prophylaxis, rabies vaccine. The vaccination is given on 0, 3, 7, 14, 30, and 90th day. Immunity lasts for 5 years. Injected on deltoid region, IMSC, not to be given in the gluteal region.
This is shield number 2, active adaptive immunity. The vaccine consists of a dead, completely inactivated version of the rabies virus. By injecting it, you are actively teaching the patient's own cellular and humoral immune system to recognize the viral antigens and begin manufacturing its own endogenous, long-lasting antibodies.
And it takes a while to work.
It takes roughly 7 to 14 days for the body to mount a robust protective titer, which perfectly highlights why we needed the immediate HRIG to bridge that vulnerable gap.
The schedule is notoriously grueling. Day 0, which is the day of the initial ER presentation, followed by days 3, 7, 14, 30, and 90. That is 6 separate clinical visits.
It requires immense patient compliance. But again, the alternative is 100% fatal encephalitis.
But I want to focus on the absolute non-negotiable physical rule regarding the injection site. Dr. Fedekimi's slide strictly states, injected on deltoid region, not to be given in the gluteal region. Why is that rule so rigid? In routine clinical practice, patients receive intramuscular injections like penicillin or certain vitamins in their glutes constantly.
It comes down to vital immunology and the unpredictable anatomy of the gluteal region. To generate a massive life-saving immune response, the vaccine must be deposited directly into highly vascularized muscle tissue, which is dense with dendritic cells and macrophages ready to process the antigen.
Okay.
The gluteal region, the buttocks, has a highly variable, often remarkably thick layer of subcutaneous adipose tissue, or fat, overlying the muscle. If you attempt an IM injection in the glute and accidentally deposit the vaccine into that fat layer instead of the deep muscle, the absorption kinetics become highly erratic.
Because fat doesn't have good blood flow.
Adipose tissue has very poor vascularity. The antigen presentation is severely blunted, the patient may fail to mount an adequate antibody titer, and they could literally die from rabies despite receiving the vaccine.
That is terrifying.
The deltoid muscle in the shoulder, by contrast, has a very thin, highly predictable subcutaneous fat layer. It almost guarantees a perfect, direct intramuscular delivery every single time. never, under any clinical circumstances, administer a rabies vaccine in the glute.
That is exactly the kind of nuanced mechanical detail that saves a life or tragically costs one if a clinician ignores it. Now, having comprehensively locked down the dog bite protocols, the virology, and the rabies PEP schedule, Dr. Fedekemi's presentation shifts its clinical focus. We need to examine the other two major culprits responsible for emergency room visits, felines and humans.
Let's talk about cats.
Let's analyze the data on cat bites. The slide reads, cat-inflicted wounds occur more frequently in girls, and their principal complication is infection. The infection risk is higher in cat bites than dog bites because cat bites produce a puncture wound. Management is similar to that for dog bites.
Right, we mentioned the puncture mechanics.
It goes on, cat wounds should not be sutured except when absolutely necessary for cosmetic reasons. P. multicida is the most common pathogen. Cat bites create a puncture wound inoculum, and prophylactic antibiotics, penicillin plus cephalexin, or amoxicillin and clavulanic acid are recommended. Scratches or bites from cats may also result in cat scratch fever.
We discussed the physical mechanics of the feline puncture earlier, but the clinical implications bear repeating because they drastically dictate your prescribing behavior.
Right.
Because the cat's tooth acts as an efficient hypodermic needle, driving Pasteurella multicida deep into the fascial planes and sealing over to create an anaerobic incubator, your clinical threshold for prescribing antibiotics must be incredibly low.
You can't just wait and see.
While you might reasonably observe a minor, superficial, easily cleanable scrape from a dog without immediately dispensing antibiotics, a true cat puncture bite almost universally mandates pharmacological prophylaxis. You must assume it is harboring a deep infection from the exact moment of injury. Amoxicillin clavulanate is again the gold standard here to aggressively counter the Pasteurella.
This line also explicitly mentions cat scratch fever as a distinct complication.
Yes, that introduces a completely different organism into the differential Bartonella henselae. This bacterium is often transmitted through cat scratches or bites, particularly from young kittens harboring infected fleas.
And how does it present?
Clinically, cat scratch disease presents very differently from the rapid, aggressive cellulitis of Pasteurella. Usually, a few weeks after the initial scratch, the patient will develop regional lymphadenopathy, massively swollen, highly tender lymph nodes anatomically proximal to the scratch site, often in the axilla or the cervical region.
Okay.
While it is usually self-limiting in healthy, immunocompetent individuals, it can cause severe disseminated disease in immunocompromised patients. It's yet another reason why feline injuries demand immense clinical respect.
All right, we've thoroughly covered the domestic pets and their associated flora. Now, let's turn the clinical lens on our own species. I'm pulling the final specific bite category from the deck, human bites.
This is a big one.
Human bites. Most human bites occur during fights. Pasteurella multicida is not a known pathogen in human bites. Cultures most commonly grow as Streptococci, anaerobes, Staphylococci, and Eikenella corrodens.
Pay attention to that organism.
Hand wounds and deep wounds should be treated with antibiotic coverage against E. corrodens and gram-positive pathogens by a penicillinase-resistant antibiotic. Risk of hepatitis and HIV infection. Wound management is the same as for dog bites. A major complication of human bite wounds is infection of the metacarpal joints. Operative debridement is followed in many cases by IV antibiotics.
I want to flag this entire section for anyone studying for emergency medicine boards or surgical rotations. This is the ultimate classic trick question and a massive limb-threatening pitfall in the ER.
How so?
If a 25-year-old male patient presents to triage at 2:00 a.m. after a bar fight with a deep, jagged laceration over his knuckles, and you culture the wound, what specific pathogen are you most terrified of? If you reflexively answer Pasteurella multicida because you associate bites with Pasteurella, you fail the board question and you potentially cost the patient their hand.
Because humans do not naturally carry Pasteurella in our oral cavity.
Exactly. You have to shift your microbial focus entirely to Eikenella corrodens.
Eikenella corrodens.
Eikenella corrodens is a fastidious gram-negative rod that is a normal, benign constituent of the human oral flora. But it is incredibly destructive and prone to causing chronic, severe abscesses when forcefully introduced into deep subcutaneous tissues or joint spaces.
And let's look at exactly how it gets introduced. Dr. Fedekemi's slide notes that a major complication is infection of the metacarpophalangeal joints, the MCP joints, the primary knuckles. It also notes that most human bites occur during fights.
So mechanically, we aren't talking about a patient presenting because someone literally latched onto their forearm and bit them like a zombie. We are talking about the blunt force trauma of a punch to the mouth.
This is clinically termed a clenched fist injury or a fight bite.
Yes, and the biomechanical horror of it is unparalleled. Here's the exact sequence when a person violently clenches their fist to throw a punch. The skin and the extensor tendons over the knuckles stretch incredibly tight, pulling taut over the metacarpophalangeal joint. In doing so, the sterile joint capsule beneath it is drawn upward and exposed.
Okay, I'm following.
The clenched fist strikes the opponent's central incisor. The opponent's tooth cuts effortlessly through the taut skin, slices entirely through the extensor tendon, and penetrates directly into the sterile joint space, forcibly depositing a massive payload of human saliva, heavily colonized with Eikenella, Streptococcus, and Staphylococcus, right into the synovial fluid.
And then the impact ends, and the patient pulls their hand back.
And this is where the trap snaps shut. The patient opens their fist. When the fingers extend, the tight skin slides backwards over the knuckle, the severed tendon shifts entirely out of alignment, and the entry tracts completely misalign.
Oh, wow. The original puncture pathway is obliterated.
Yes. The bacteria are now sealed tightly inside the synovial joint capsule, trapped deep beneath what now appears to be perfectly intact, superficially healed skin. It creates a perfect, impenetrable incubator for Eikenella to rapidly destroy the cartilage and the bone.
That is an unbelievable biomechanical trap. The simple act of unclenching your fist seals your fate.
Exactly. This is precisely why a simple, seemingly superficial 1 centimeter laceration on a knuckle following an altercation is considered a surgical emergency. You cannot just scrub it with iodine and hand them oral antibiotics. It almost universally requires operative debridement.
Meaning an orthopedic or hand surgeon must take the patient to the operating room.
Yes, surgically open the joint capsule, mechanically irrigate the synovial space, and initiate heavy, targeted IV antibiotics.
And obviously, we cannot ignore the virological reality of human-to-human blood and saliva transfer. The slide points out the critical risk of hepatitis B, hepatitis C, and HIV infection.
Right, which means a human bite doesn't just trigger bacterial prophylaxis. It triggers a comprehensive, urgent, viral post-exposure prophylaxis protocol requiring baseline serology, potential hepatitis B immune globulin, and potentially a 28-day antiretroviral regimen depending on the source patient's known status.
A human bite, particularly a clenched fist injury, is arguably the dirtiest, most structurally complicated, and pharmacologically intensive bite wound you will ever manage in a clinical setting.
I completely agree.
We have covered an immense, incredibly dense landscape of trauma, virology, and pharmacology today. Let's pull all these clinical threads together and bring this deep dive to its final conclusion. I'm looking at Dr. Fedekemi's final summary slide.
The conclusion.
Conclusion. All bite wound victims should be reevaluated within 24 to 36 hours after the injury. Prevention is better than cure. India, around 30,000 die with rabies. Nigeria, no statistics. Vaccination of the dogs and licensing of the dogs should be mandatory. Avoid all forms of bite.
That very first bullet point, reevaluated within 24 to 36 hours, is your ultimate clinical safety net.
Because things can go south so quickly.
Because we are purposefully leaving these wounds open to heal by secondary intention, and because highly virulent organisms like Pasteurella and Eikenella can cause aggressive limb-threatening cellulitis overnight, you never just irrigate a bite, hand them a prescription for Augmentin, and say, come back in a week to get your stitches out.
You must mandate that the patient returns to the clinic or the ER the very next day.
You must physically inspect that tissue to ensure your empiric antibiotic coverage is actually halting the infection, and that the erythema isn't streaking proximally up the lymphatic channels or the flexor tendon sheaths.
To recap the incredible clinical journey we've taken through Dr. Fedekemi's deck today, we started by identifying the high-risk zones, like the poorly vascularized hands and feet, and the physics of puncture wounds that create perfect anaerobic incubators.
We learned the crucial distinction that while massive dog jaws cause devastating blunt force trauma and cranial fractures in toddlers, the needle-like teeth of cats are highly efficient delivery systems for deep Pasteurella infections.
We completely broke down the biomechanical trap of the human clenched fist injury, requiring surgical intervention for Eikenella corrodens. And then we tracked the terrifying, biologically flawless journey of the bullet-shaped lysovirus.
We watched it use its glycoprotein G spikes to perfectly forge an ID badge, picking the lock of the nicotinic acetylcholine receptors at the neuromuscular junction.
We calculated its silent, 12 to 24 millimeter a day retrograde crawl up the axoplasm via dynein motors, completely shielded from immune surveillance, before exploding centrifugally from the brainstem to cause the horrific dysautonomia and pharyngeal spasms of hydrophobia.
And most critically for the clinician, we mapped out the exact defense. The immediate deployment of the ISA protocol using simple soap and water to chemically shred the lipid envelope of the virus.
The localized high-volume infiltration of human rabies immunoglobulin directly into the wound margins to neutralize the virus during its amplification phase, followed by the strict, non-negotiable 0 to 90-day active vaccine schedule, delivered exclusively into the vascular deltoid muscle to ensure robust antigen presentation.
It's an exhaustive protocol, but it's our only defense.
The presentation also notes that World Rabies Day is observed on September 28th. This specifically honors the anniversary of the death of Dr. Louis Pasteur, the visionary who stabilized the fixed virus through serial passage in rabbits, giving humanity its first fighting chance against a disease that had represented a guaranteed death sentence for millennia.
His ultimate vision was a rabies-free world.
A goal that, as the slide's grim statistics on India and Africa point out, requires massive, coordinated public health infrastructure, mandatory dog vaccination, and comprehensive stray population control.
Rabies is ultimately a devastating disease of poverty and failing public health infrastructure, just as much as it is a masterclass in virology.
Before we sign off, I want to leave you with a final provocative thought to mull over. Something that builds on the incredible virology we unpacked today, but looks toward the future of medicine.
I'm intrigued.
Think about the terrifying biological perfection of the rabies virus. It is entirely, flawlessly, a creature of the nervous system. By perfectly mimicking our own endogenous neurotransmitters to slip seamlessly through the acetylcholine doors, it turns the human body's own neural communication highway into its private high-speed transit system.
It really does.
It moves via retrograde transport, hiding entirely from the incredibly sophisticated immune system patrolling our bloodstream until it is firmly locked inside the central nervous system.
Where it's untouchable.
If a mindless, microscopic package of negative sense RNA can evolve to engineer such a flawless, targeted, highly efficient delivery system directly past the blood-brain barrier and into the deepest structures of the human brain, imagine what modern molecular medicine could achieve if we could fully reverse engineer that exact mechanism.
Wow, that's a profound idea.
Imagine if you could strip out the lethal viral RNA, retain that perfect bullet-shaped lipid envelope and those highly specific glycoprotein G spikes, and pack the interior with life-saving neurological drugs, gene therapies, or targeted chemotherapies.
A targeted delivery system straight to the brain.
Exactly. The greatest hurdle in modern neurology is getting systemic medications past the blood-brain barrier to effectively treat Alzheimer's, Parkinson's, or aggressive glioblastomas. Next time you review the fatal pathogenesis of a rabies exposure, consider the profound possibility that the ultimate biological key to curing our most devastating neurodegenerative diseases might be hiding in the exact molecular mechanics of the very virus we fear most.
That is an incredible thought to end on.
Thank you for joining us on this deep dive into Dr. Fatakemi's masterclass on clinical bite management. We hope you feel incredibly well equipped, confident, and prepared for your next high-stakes clinical rotation, your board exams, or your next chaotic ER shift. Keep questioning the mechanics, keep pushing for the why behind the protocols, and please aggressively wash your hands and your patient's wounds with plenty of soap.